Good afternoon, everyone, and welcome back to Grand Rounds for the 2025-26 diet. I hope you've had a nice summer. It is definitely over. Well, actually, just looking out of my window, the sun has come out suddenly here, so perhaps we'll have a second summer. But welcome back. It's now, I think, when did I start doing this? 2013. So this is now our 13th year of chairing Grand Rounds and organizing things. Um, and build it and they will come, so they say. And I'm delighted that we're still here, we're still kicking, and we're still drawing in expert, exciting speakers from all over the country, nay, the world. So, and we're starting off Grand Rounds this diet with external speakers from across the country. The title of today's talk is centered around generalism. And we have experts in the field who are going to talk to us about generalism and sustainable healthcare. Professor Sophie Park, Dr. Kay Latham-Green, and Professor Lindsay Pope are going to speak to us from, I think, Glasgow and also from Oxford and from Imperial College in London. And I think we've got a video as well, so hopefully the technology will work and we'll all be fine. So, as ever, you feel free to leave your cameras on if you wish. Please do stay muted though. You can put questions into the chat along the side, and there will be an opportunity at the end to ask questions in real life if you want. Thank you, all three of you, for coming. Thank you to Ellie Hothersall, who organised this in the background. I'm very much looking forward to your talk. And again, welcome to Dundee Grand Rounds.
Thank you, Professor Farden. So a little bit of a wave if you can see what I'm trying to show you. But I'm Dr. Kay Latham-Green from Imperial College London, and I'm joined by Professor Lindsay Pope from Glasgow. And we have a video contribution from Professor Sophie Park from Oxford. And our thanks to Professor Ellie Hothersall for inviting us, and of course, Professor Farden for hosting today's session. We're excited to contribute to Dundee's impressive Grand Rounds programme and to engage with you all in critical debate about healthcare, learning and practice. And we're here to highlight what we believe to be a disconnect between higher education and what's needed for sustainable, equitable, affordable clinical practice. And this concerns us all as both consumers of healthcare as well as healthcare workers. And we're going to throw up some challenges and perhaps leave some of the solutions for us to discuss and co-construct at the end. So, as I said, I'm Kay. I'm a senior academic from Imperial College London, and I specialise in clinical education and health services research. I'm also co-author of an international consensus statement with Ellie on education for sustainable healthcare, and with Professor Sophie Park, a new book on clinical generalism, which also has contributions from both Lindsay, Ellie and Sophie. Lindsay, do you want to introduce yourself?
Yeah, thanks, Kay. And it's nice to see some familiar faces on the call. For those of you who haven't met me before, I'm Lindsay Pope. I'm a GP. I work in the deep end practice in the west of Scotland. I'm down in Port Glasgow, for those of you that know the west. I'm a professor of medical education and one of our international deans here at Glasgow University. But I also have a number of other different hats that I wear, depending what context I'm in, depends what hat I'm wearing. So I have roles at NES, and I'm also the director of the Scottish School of Primary Care and do some work for both the GMC and the Royal College of GPs, and particularly in relation to assessment. I tried to think of how to summarise my areas of research interest, and I've sort of put them up on the image there. But I think the key thing is that actually when I think about it, I'm both a clinical generalist, but I think I'm also both educationally a generalist, which is why there's that spread there. Next to the very out-of-date staff photo that Kay must have uploaded from my staff profile for your amusement.
Brilliant. And of course, this presentation is co-created with our colleague Sophie Park from Oxford. She is Professor of Primary Care and Clinical Education at Oxford, and also GP in Hertfordshire. And she used to be head of the primary care education at UCL and leads the Department for Primary Care, Workforce and Learning at Oxford. So we're going to divide our talk into 4, followed by a discussion. And in the first section, I'm going to share some data and conceptions of sustainable healthcare. Sophie will next give a short video on what we mean by generalism. Next, I'll come back and share a vignette, which hopefully, if there are any medical students here, to show how sustainable healthcare works in action. And then Lindsay will throw up some of the more complex challenges for clinical education, hoping to stimulate some cross-disciplinary debate. So firstly, some background. So as we are all aware, our health system is beset with social, political and economic challenges. And most of us are familiar with our economic and workforce challenges. But arguably, healthcare's greatest and possibly most neglected challenge is environmental degradation, on which all health depends. What's less known is that healthcare itself is, let me just get my laser pointer up, is one of the greatest contributors to global warming. So if this graph here shows CO2 emissions per country, not per capita. But if the global healthcare industry were a country, it would come in somewhere here between Russia and Japan. And that's roughly twice the size of the global aviation industry. So without sustainable healthcare, there's little prospect of a sustainable planet. So this graph shows the CO2 emissions of the health sector in England. And in the front row here in green, we have primary care, and behind it in darker blue, secondary care, and with kilotons of CO2 on the y-axis and sectors across here going into the distance. When I talk about sustainability, people often think about recycling, energy and transport, but waste management only accounts for less than 0.1% of the overall carbon footprint. Recycling is not going to fix this. The main hotspots relate to our clinical practices and priorities. These hotspots include medical equipment and consumables, such as PPE, including 1.4 billion gloves per year just in England. And these consumables occur mostly in hospital-based care, which is more technologically based. However, the biggest contribution is from pharmaceuticals, most of which are prescribed from primary care, arguably to avert secondary care admissions. And inhalers down here are also a surprisingly large slice due to the high global warming potential of CFC-free inhaler propellants, not the medicine. So if we thought we were creating a healthier population through our current healthcare paradigm, we might perhaps carry on. But in fact, this is what's happening. This graph shows how life expectancy on the y-axis is changing for men and women across different deciles of deprivation. And it shows how those in the most deprived deciles are seeing the largest reductions in life expectancy. And even men in the most privileged decile are seeing a fall. So our unsustainable healthcare paradigm is not only driving up the carbon footprint of healthcare and damaging the environment, it's failing the most vulnerable members of society. So politicians would have us solve the problems of the NHS by increasing productivity, doing more healthcare with fewer resources. But a very basic understanding of health economics is necessary here. If we're doing more healthcare, it probably means our population is sicker. What we need to do is drive down the need for healthcare, and then to do what healthcare is necessary in ways that are more effective and efficient, not more productive. So financial sustainability and workforce sustainability are often prioritized over environmental sustainability. However, these are all interrelated. A stable business model requires a stable workforce, and a stable workforce requires a stable environment on which all health depends. And I hope to show you that environmentally sustainable generalist care can also drive workforce and financial sustainability. This driver diagram here on the right shows that if we want a sustainable, equitable healthcare system whilst maintaining the quality of care, we need to reduce demand through effective public health and prevention, and also supported self-management and patient engagement. We also need to increase the efficiency of the healthcare that's needed through lean clinical pathways, swapping for more sustainable and affordable treatment options, and optimizing our operational resources. Look at these top two drivers here. These are all aspects of clinical care that tend to be delivered by generalists. So, how do generalists drive down the need for care? Over half the consultations in primary care and over 70% of hospital admissions relate to chronic conditions such as these here on the right. These chronic conditions are partly genetic, but mostly driven by these health behaviours, which are in turn driven by social, psychological, and environmental determinants. Sustainable healthcare requires us to focus on more root cause approaches within clinical education and practice. Doing more healthcare will never be a panacea for abuse, deprivation, or poor housing. Part of my role as a generalist is to initiate conversations inviting change, or to signpost and refer people to local resources. And I also appreciate that genuine change takes time and requires continuity. So this is our video from Sophie Park. Lindsay, rather than me faff around, do you want to see if you can play? I'll stop this share and then see if you can play from your screen. Is that all right?
Yeah, I can do that. So, place current share, share sound. Now.
Hello, my name is Sophie.
And I can't hear you, Lindsay.
Professor of Primary Care and Clinical Education at the University of Oxford. I'm sorry I can't be with you today. I'm in clinic, but I know you're going to have an excellent...
Oh, that's annoyingly not working either.
Still not working. Okay, I'm going to try one more time.
Try yours.
I do sort of know. But
I did do the optimized sound bit, but it didn't.
For what it's worth, we could see it and we could hear it.
Oh,
right.
You could see and hear it. Will I redo it then?
So I have to share
I mean, it was
as well
not
as
the
this.
most optimal frame rate, but I think we could manage.
Well, Kay, will I just redo it then? Okay.
Hello, my name is Sophie. I'm a GP and Professor of Primary Care and Clinical Education at the University of Oxford. I'm sorry I can't be with you today. I'm in clinic, but I know you're going to have an excellent discussion with Kay and Lindsay and Ellie and others. So thank you for bearing with me for a couple of minutes on this video. I'm going to think with you about generalism. So before we move on to the slides, I just want you to ask yourself, am I a generalist? Am I a specialist? Or am I a bit of both? And we'll come back to that later in the talk. So we have a problem, a mismatch. We have increasing societal need for generalists, for example, with artificial intelligence, aging populations with multimorbidity, and many global compound pressures. So by that, I mean unpredictable challenges such as climate change, migration, I've mentioned AI, and winter pressures. So these problems require clinicians who are expert in undifferentiated, integrated, and complex illness. Yet, at the moment, as these needs increase, we have a reduction in capacity and supply, particularly in areas of deprivation, and this further widens the inequality health gaps. So we need to extend our understanding of these issues, not only to explore individual choices about careers, but also to think about the nature of generalist work, the social interactions, the power relations, and how and why the system is operating in particular ways to perpetuate many of the problems we're experiencing at the moment. So there have been a number of attempts to solve this mismatch. In the UK, for example, we have the long-term plan a couple of years ago, which invested heavily in shifting work and expansion of additional healthcare professional roles. We've had increasing recruitment across borders, and we know that international medical graduates now account for 2/3 of new joiners to the GMC register. In some areas of the UK, 80% of GP trainees, for example, are now IMGs. Yet, IMGs are underrepresented in training places, so 16% of all non-UK graduate doctors securing a training place in 2023. And there is still a differential awarding gap. So we need to look at some of the root causes. So while the Department of Health and Social Care estimate needing around 50% of undergraduates to become GPs and/or generalists, the Career Destination Report and subsequent similar reports have shown around only 20% of UK graduates intend to pursue a GP career or a generalist career. The numbers taking up GP training posts are reducing despite an increase in training places. In a recent study that one of my PhD students has done, which is Impress, which was looking at UK med data, we can see that those choosing to be a GP, for example, were more often women, lower socioeconomic status, state educated, and had lower medical school performance. We have low levels of general practice funding, which we have for many years in the UK, with around 8% of the budget and estimated 90%. And we still get reports of stigma across different areas of the healthcare system and in the media and society more widely. So we have an opportunity in the UK with the new 10-year plan to really address some of these problems. We've got the 3 key priorities: moving from secondary to primary care, moving from treatment to prevention priorities, and thinking about shifts from analogue to digital. So what do we need to do next? Well, I'm briefly going to share with you a couple of findings from a recent Realist review looking at GP workforce sustainability. So this produced causal explanations about GP workforce sustainability and aimed to look under the bonnet, if you like, at the nature of the system and how this could facilitate joy in general practice work. So I'm not going to share all of the findings with you, but just some key points. GPs need congruence between their values and the nature of their work. So when work is meaningful and aligned with their values, people are more joyful and more productive. We need to be careful about assumptions that remote working makes work faster. Often remote working can increase workload through increased patient expectation, for example, reduced breaks and reduced time with colleagues. We need to acknowledge the importance of cumulative knowledge in the ways that we design and operate both healthcare and training. So building and implementing shared knowledge of people and place to improve patient care. And we need to maximise direct connections between GPs, patients and peers to enable GPs to flourish and experience psychological safety, particularly during negotiations of risk, ambiguity and uncertainty. So while the long-term plan sought to address many aspects of the GP workforce challenges with increased additional healthcare professional roles, our analysis shows that this can produce considerable challenges. More indirect interactions can increase GP burden of risk, and they can experience more emotional and cognitive load, seeing more complex patients, when more straightforward patients might be delegated to other healthcare professionals. So we need to think about generalism differently, to challenge some of these knowledge power hierarchies and make visible the expertise inherent in general practice and generalist practice across disciplines. This was a systematic review we recently did, which is Impress in the Canadian Journal of Family Practice, about generalism and generalists. The left-hand column shows one end of the spectrum around specialist norms, and the right a more generalist ideology. So in a specialist paradigm, knowledge tends to be characterized as something which can be compartmentalized and acquired. Many papers referred to generalists having a knowledge deficit and suggest addressing this lack of knowledge through training or acquisition of knowledge. Through this lens, generalist knowledge is perceived as basic and specialist as complicated. Many of the research methodologies used in this paradigm tend to be comparative. On the right, generalist knowledge tends to be characterized as expansive, meanings created through interactions and socially situated. It's relational, contextual, and interconnected. Expertise and critical reflexivity is required within this paradigm to judge how, when, and if to implement. Recommendations for learning, therefore, tend to be much more about workplace-based learning, patient-based learning, and critical reflexivity. So an example we use in this paper is the different meanings attributed to the word complexity. So complexity through a specialist lens is used to mean severity or complicated biomedical disease, whereas the word complexity is often used in a generalist paradigm to mean integration or coexistence of multiple biopsychosocial eco aspects of care, the management of multimorbidity and navigating the interface between the biomedical and experiential knowledge. So we need to celebrate, better articulate and value generalism. I know Kay is going to expand on this in more detail, but just to summarize, a generalist is an inclusive clinician. They are an expert at complex, situated and unique patient problems. They value partnership, inclusivity and distributed power. They know through distributed expertise, integration of multiple knowledge forms, biomedical and other knowledge forms, and they know through situated knowledge about people and place. And they do their work through collaborative problematization, responsive and agile implementation, and coordination and navigation of care between individuals and systems. So what are our priorities at this point in time to help build next steps? We need to better articulate and value the nature of generalist work and roles to improve our work, recruitment, retention and training, and celebrate generalism within general practice and across disciplines. We can then expand the generalist workforce to enable capacity to strengthen collaboration with community assets, secondary and community services to help support patient care better. We need to improve the coherence and connection between healthcare policy and education workforce strategies. And finally, we need to develop more inclusive and adaptive approaches to work and training, enabling our workforce, embracing a range of gender, deprivation, ethnicity, and so on to thrive, particularly widening participation for students and support for international medical graduates. Thank you for listening.
Great. So, let me just get my next slide. Sorry. Sorry. Okay. I'm going to have to stop share again. My technology.
The joys of modern technology, Kay.
Next slide up. Seem to be progressing. Start the PowerPoint again. Here we go on this slide. Swap and share. Sorry about this. Nearly there. Great. So moving on to part 3. Oh, sorry, do I need to change the microphone? No, that's still okay. Generalism in action. Moving on. Okay, so just a quick, perhaps slightly lighter introduction to generalism. So this is a form of clinical practice that is slightly different to specialism, but generalism is certainly not confined to general practice. One of the best trauma surgeons I know, Martin Griffiths, uses generalist approaches to address his patients' problems beyond the operating theatre. And he's now our National Clinical Director for Violence Reduction. And many of you know Professor Jane Dacre, recently chair of the Royal College of Physicians, and she considers herself first and foremost a generalist. So what is a generalist? So generalists instinctively adjust their remit to fit the needs of the person in front of them. And I rely on distributed expertise and collaborate with specialists for specialist solutions as needed. I'm also an expert in complex problems that don't fit neatly into randomized controlled trials, or for that matter, single best answer questions. For example, how to support someone with frailty or dementia. I'm also an expert in everyday problems that need personalized approaches. For example, supporting people with eczema or in choosing their contraceptives. Importantly, I treat my patients as experts in their own lives, and I make no decisions that affect them without them. And I've learned how to provide personalized care because these problems really matter to people and no one is the same. The knowledge that I have is dynamically constructed through practice in response to patient needs, and it's therefore inherently shaped to the needs of the people in the area where I work. And before Lindsay introduces you to our educational conundrum, let me show you how generalism contributes to sustainable healthcare through a clinical vignette. So please note this is a constructed vignette with posed photographs rather than a real patient. But meet Abdi, a typical patient, and Faith, one of my medical students. And if you have a pen, I invite you to jot down the types of knowledge that I implement as I work with Abdi. And also, if you're an educator, to think about how Faith is learning and being assessed on this knowledge. So Faith is on a longitudinal placement with me. So she's embedded in my GP practice for a whole year, where she's expected to learn all of her community medicine across all specialties. I've known Abdi and his family for 5 years. Abdi has a 3-month-old daughter, Aya, and a 5-year-old son, Adam, who has autism and some developmental delays. Abdi has had an extremely difficult year. His wife has left the family home and he's left his job to care for his children. Over lockdown, he was bombarded with social media claims and became vaccine hesitant. Faith has been shadowing our health visitor, Francis, and discussing the risks and harms of vaccination with him. Abdi has finally agreed to immunise baby Aya, but insists that we give the immunisations individually. So we sit down, Francis, our health visitor, is overstretched, so we sit down and agree a personalised vaccination schedule. And Faith and I will deliver these together. So at the first vaccination appointment, Abdi appears withdrawn. He's undernourished, unwashed, and smells of tobacco. I notice his hair follicles look inflamed. I ask him if his gums are sore. They are. He probably has scurvy. I invite Faith to assess these signs. Despite 4 years at medical school, Faith is unsure where to begin. We discuss the importance of vitamin C, and Abdi agrees to eat a fresh orange every day for a week. But this hasn't addressed his underlying malnourishment. I ask Abdi what he feels the issues are and what might make a difference. He explains how hard he finds parenting without his wife. The worst thing is the loneliness. But he's also worried about making ends meet. I ask Faith what her approach might be. She suggests antidepressants. Instead, I suggest Faith introduces Abdi to our local health justice partnership, who will organise a benefits and rights review. I also ask Faith to help Abdi research local community groups for parents with children with autism. After Abdi leaves, Faith and I debrief, and she agrees to spend the afternoon preparing a presentation on malnourishment for our fortnightly practice learning group. At the next immunisation appointment, Abdi bursts into tears and thanks us. His gums have cleared up. He's made friends through the parenting group recommended by Faith. He's claiming carers allowance and has developed new strategies for supporting Adam. I ask Abdi what he would like to work on next. He's unsure, but knowing him, I suggest perhaps smoking or perhaps healthy eating on a budget. He says both. I ask Faith to lead this next appointment as she's recently passed an online smoking cessation course. I suggest Abdi brings a week's plan of affordable healthy meals to his next appointment. Having seen Faith's presentation, I'm confident she will check it covers the main food groups and help Abdi troubleshoot. With Abdi's permission, Faith gives Aya's next vaccination under my direct supervision. I know she's passed an immunisation practical, but I know she also needs strategies for squirming babies and curious older brothers. At the third appointment, Abdi appears much brighter. He's still smoking, but not in front of his children. Aya is clearly flourishing, and Adam is at nursery school. Faith asks Abdi what he'd like to work on next. He says he'd like to have another go at quitting smoking and perhaps learning more about autism. They agree a plan and set a quit date with follow-up. Faith has started to call Abdi and his family her patients. And you might ask, what has this got to do with sustainable healthcare? And the preventative approach is the key, driving down the need for healthcare. Just focusing on his smoking cessation, Abdi is aged, where's my little pointer again? Here we go. Abdi is aged 33 and smokes 10 a day. If he continues, he has a 25% chance of getting COPD and needing inhalers. And a single person with COPD using 2 puffs of inhaler twice a day would use 144 inhalers over their expected 12 years of ill health. That has a carbon footprint of over 4 tons of CO2 due to the high global warming potential of the inhaler propellant. And each smoking cessation gives him a roughly 20% chance of quitting. And there are currently 1.2 million people with symptomatic COPD in the UK, using 1 in 8 hospital beds. And we prescribe approximately 20 million COPD inhalers per year, at roughly 28 kilograms of CO2 equivalent per inhaler. COPD is a preventable disease that's predicted to increase by 40% as current smokers age. There are many other ways I can support the environment through my generalist clinical approach. Nutrition has now overtaken smoking as the #1 cause of illness in the UK. I could have pathologized his poverty and started him on antidepressants. I could have simply ticked the non-compliant box on baby Aya's vaccination schedule, leaving her vulnerable to a lifetime of illness. I could have labelled Abdi a problem parent when he simply needed support. So over to Professor Lindsay Pope.
Thanks, Kay. And for the last section, what I want to do is pull together some of what Kay and Sophie have been highlighting and actually think about how that relates in particular to our medical curricula and the wider educational systems in which we function. And so I wanted to start by talking about generalism and knowledge paradigms. And I'm aware some of you will be very familiar with concepts such as knowledge paradigms, but I could spend another hour talking about that, but we won't. But just to touch on it very briefly, I want to get people to think about what we value as knowledge when we talk about medicine. Traditionally, we often value the very disease-based models of thinking about knowledge, talking about teaching things.
Sorry, Lindsay, I can't hear you.
Can other people hear me?
I can hear.
Yeah.
I can
Lindsay.
hear Rand.
Yes.
I think
Computer sound.
Oh, can you put the slides back up, Kay?
There.
Or do you want me to do them? A minute. Can you hear me now, Kay? A minute. I might do the slides because Kay's got the control. Okay, so why don't I?
We can hear grand.
Can you hear, can you see,
I can hear good.
can you see my slides? Can someone just give me a shout?
Yeah, I can see the slides.
And you can hear me.
And
Fabulous.
loud and clear. Loud and clear.
Brilliant. Yeah. So a
Lindsay,
medical,
can you possibly show
Yes.
it? I just literally can't. I'm
Thank
clicking
you.
all the
Can
sound
someone
buttons
type
and it's
that,
all over the
that
place.
you, can
I can
someone
hear
type
both. I
so
can hear.
Kate knows? Oh, the joys of technology. Yeah. So basically, what we often focus on is that very biomedical way of thinking about knowledge and medicine. And I suppose I wanted to get you to think about how that applies to knowledge paradigms, and what we think of as ways of understanding and applying knowledge and practice. So when we use the word paradigm, really all we're talking about is how people view the world, because that shapes how they define the problems they encounter in their daily practice or work, but also the knowledge that they're going to generate if we ask people to generate new knowledge, but also what they think of as being truth or fact. And when you think about how that applies in medicine, actually, there's lots of different paradigms at play, and that often guide how we approach the patients who sit in front of us, but also how we understand illness and how we act as clinicians. So to give you sort of breakdown of sort of some of the ways we think about it, so we would talk about the fact there's that very biomedical paradigm that's really precise, it's evidence focused, it's looking for measurements. So if you think about it in the context of a patient who's got diabetes, it's that focus on, can I measure their hemoglobin A1C, perhaps to diagnose them or monitor their diabetes? If I was looking at it from a much more psychosocial perspective, I might recognize that actually the fact that patient is depressed and really isolated is making it really difficult for them to manage their diabetic control. But that's a much harder thing for me to measure and evidence when we talk about quality of care. Then it might be thinking about it through a narrative paradigm. So actually, if you think about the example Kay gave, actually understanding how living with diabetes might be impacting someone's daily life, because that might enable me to develop rapport with that patient and actually to help empower them to take a role within their own care. But again, doesn't translate really well into guidelines. And then we have the sort of systems and complexity that we need to navigate, the stuff that I call sort of the messy reality of clinical practice. And if we see health as a kind of outcome from all these interconnected systems, and often we see guidelines as being really simple and linear solutions, but they don't often fit the patient sitting in front of me. And often I'm trying to balance priorities, managing different medications, multiple medical conditions, and all that kind of messiness of real life practice. So we would argue as generalists, often we move between all these different paradigms, but also integrate them. And when I reflect on how well we prepare our learners for this, I think it actually gets me to think about what's some of the problem with medical education, both in the past and currently. And I think some of that is rooted in the history of why medical education has ended up where it is. And there's a couple of images here. So one represents Descartes' work back in 1662, where they talked about the sort of philosophical separation of the body from the spirit as being two completely different things, that strict separation. But actually, in reality, we're starting to understand that these two do interact, and it's much broader than that very traditional biomedical model. In the Flexner era, medicine then became seen as the practice of medicine, became seen as a profession that was really grounded in the biomedical sciences and lab-based research and teaching in hospitals. And you can see that reflected in a lot of medical school curricula over the last century, with some curricula now starting to evolve much more to recognizing the additional value from thinking about the social, the psychological, and the community aspects of health. So where are we now? So we've ended up in 2025 in a situation where we've got medicine being taught predominantly, but not exclusively, still as a very positivistic science. So really emphasizing the correct facts, the information that can be the single truth and the right answer to things. And we get our students to do lots of these exams. And are we somewhat ignoring the kind of social, psychological, and practical elements of real life clinical practice? So we've seen the MLA introduced, which is the new medical licensing exam. And although as medical schools, we've all been evaluating this students this way for many, many years, actually, I think that it is starting to result in some changes across the board about how curricula are responding because of that sort of reduction of autonomy at individual school level. Because even then, when you complement it with those short practical tests of competency that you have in the way of OSCEs, actually how much are those judgments that you get from a multi-choice question or an OSCE question going to tell me how well prepared my learner is for dealing with somebody who presents to an emergency department in Glasgow on a Saturday night with an undifferentiated presentation of symptoms? And I'm not saying there aren't any merits in having a national licensing exam at all. I don't want people to misunderstand that. But actually, we need to think about how are our curricula responding to those and what's the risk of responding to those, because what's being lost or deprioritized in our curricula as a result of that. So I wanted to elaborate on that a little bit further and say why it can be a bit of a problem. So as educators, if we are thinking about what we want our students to learn, we'll typically start from the point of view of thinking about our intended learning outcomes. We'll then design our teaching and learning activities informed by those outcomes. And then we'll add on the assessment to check whether our students have learned what was actually intended. But Biggs reminded us that our students don't start in the same way as the process. They often start from the assessment part of the process. To them, they often perceive that the assessment is the curriculum. You know, the number of times I've given a lecture and someone has said to me, oh, is this going to be in the exam? Because the students will strategically learn what they think is going to be assessed, not what's necessarily covered in the curriculum, or even what we've been covered in one of my lectures. Oh, so now I'm getting pinging messages, we'll leave them. So the trick is to make sure that how do we get our assessment tasks to actually mirror our intended learning outcomes? Because otherwise we're all going to end up drifting towards this focus on a very narrow view of what should be taught, which is informed by what we currently assess and prioritize within our curricula. You can see that all lining up there. So thought we'd pull out a specific example to give you an understanding of what we mean. So this is a question that comes from the mock MLA question banks that's on the GMC website. The actual exam has got 200 papers and it's 200 questions and they're split across 2 papers. So Kay spent a lot of time reviewing the mock exam and identified in the ones that were available at the time that there was no questions that related to patient education or engagement with team working, how to work across different boundaries, or actually how to address the social determinants health. There was a representation that the majority of questions were very much focused on this test and treat model, following rote learning and following guidelines, which actually are all the time encouraging us to do more rather than less healthcare. I talk a lot about prescribing, and I'll say to our students, you know, we spend hours and hours and hours teaching our students how to prescribe and hardly any time at all teaching people how to de-prescribe. So the question you see here about managing a patient who is experiencing morbid obesity is the closest that Kay could find to a preventative question. So that you can imagine if you were thinking about this, this no way represents the complexity of talking to a patient about their weight. It's simply a test of do they know the referral criteria for bariatric surgery or not. But the reality is many of our patients who are morbidly obese are actually survivors of complex childhood trauma, and surgery is not going to fix that. And if you think about it from a healthcare sustainability point of view, there's about 2.1 million people in the UK who currently meet the criteria for obesity surgery. But we've got a surgical capacity in the NHS for about 5,000 of those operations per year. So I'll let you do some of the maths on the backlog that would create. So our worry is that not only does preventative care not feature in that assessment, but neither does multimorbidity, frailty, poverty, or sustainability, which are often the real life challenges that are faced by our learners. And one of my colleagues, as part of her master's, actually did some interview studies with our students to find out what that complexity and that messiness in real life practice feels like to them. Because we are in theory preparing them for real life practice when we are not trying to just prepare them to pass a test. And now we heard from our students that they find it really overwhelming because in medical school, you're told a patient comes in with classical symptoms, then they go and clerk someone in the hospital. And then actually there's just so much in there. And they're used to being given everything in these lovely, neat and tidy bite-sized chunks, rather than having to do all that integrative work that we were describing earlier on. And they recognize that they've not had a huge amount of practice in that. Because when they do learn, they learn everything in isolation. And the way I often frame it to people is that it looks a bit like this sometimes when you look at medical school curricula. This is a plate of different species of tomatoes, and we like to do everything in nice, discrete, tidy tomatoes. We say this is your surgery block, or this is your cardiology block, and this is your neurology block. And then the students go out onto placement, and placement looks more like this. So some of you may recognize this as a picture of a tomato throwing festival in Spain, where tourists pay money to go to this village and locals throw lots of tomatoes at them, allegedly in the name of fun. But actually, how does a student make sense of all of this when we've taught them the world a completely different way? And this is what I love about general practice. I think I love the messiness and chaos of general practice, but to our students, it can be really overwhelming. So what could we do to better prepare our students, and what could assessment of the required generalist skills look like? So this is a paper that a number of us across a number of UK medical schools have just had out in the last few months, talking about the possibility that entrustable professional activities as part of a workplace-based learning might be a way ahead, recognising that what those students will be learning and therefore being assessed on is really in response to emerging patients' needs, and thinking about that much more dynamic way of learning and learning through and assessing through the actual practice. So the concept of EPAs is based on the work of Ole Tenkata, but if you aren't as familiar with it, in a nutshell, it basically means you're not relying on that single judgment of performance at a single moment in time. So you're not just judging, can somebody do something in an OSCE in a very sort of sterile, contained setting. It then also lets us think about what that student's personal level of scaffolding that they'll need to enable them to progress in their learning. So it's a much more sustainable and real world way of helping to assess our learners' progress. So I thought a worked example might help. So this is an example of if you had an overarching EPA, could be, can the student provide comprehensive care for a patient with a chronic disease in general practice? So that's very broad. And ultimately, you're trying to judge, can this learner be trusted to take responsibility for the holistic longitudinal management of a patient with chronic illness in a general practice setting? And then what you can do is you can break it down into the different EPAs that they might need to be able to demonstrate. So can they conduct a focused history and examination, for example? Can they order and interpret common investigations that might be undertaken in primary care? And you can see there the different steps and how you then break it down to get a much better picture of the student's ability to progress to the next stage of training and are they ready for that entrustment, as we call it. So that kind of leads me back to our final slide and sort of our questions to you for our discussion. We want to ask you, do you feel there's a fundamental mismatch between what we value as a profession and society when we think about healthcare, but actually what our students need to learn to function as generalist clinicians? Because they're all going to need to be able to function as generalist clinicians. It's not just GPs. And that's for us to then enable a sustainable healthcare going forward, as outlined in Kay's example. This last slide here has the different domains of what a sustainable healthcare should look like. And we would question actually which of those are evident in our current assessments that we are using with our medical students and as part of our curricula, in particular in this new era of the MLA. Our worry is that as these complex and nuanced domains of learning are being devalued, they're then being pushed out of our core curriculum, and that's been driven by some of the assessment changes. And not only are we doing our patients a disservice, but we're also doing our learners a disservice when it comes to preparing them for their future clinical practice. We would argue we need to integrate these and assess these throughout our course, because until healthcare becomes sustainable, the world is not going to become sustainable. So, as we said right at the start, are our students at risk of passing the test, but perhaps completely missing the point? So over to you at this point. We are generally interested to hear your thoughts. So I'm going to stop sharing slides. And
thanks very much to both of you in the virtual room, and also to the videos, and some slight technological teething at various points, but we're all in this together, and we're out the other end. So thank you very much. I think this is all a very interesting topic generally. in journalism. I said in my introductory email that I sent late last night, there has been when I think back to being at medical school in the 1990s, generalism was something that was aspired to, and people took a great amount of pride in being a generalist. And the professor of medicine, and you'll forgive me for saying medicine because I'm a medic, not a surgeon, but the professor of medicine was the generalist, who was the pinnacle in many ways of a teaching hospital. And Kalmanization, MMC, etc., has all moved us away from that. And despite the GMC's words, at least, to say that we're moving back to a generalist curriculum and generalism is important, I think it's reasonable to say that we haven't actually seen that in practice, and that much of what was said initially in those GMC documents has been diluted in medical education. And I think this is very challenging. So I'm very supportive of journalism. I sit here thinking, I do cystic fibrosis. I'm the CF doc for the hospital, and most of my time in CF clinic is spent talking about sore knees and sexual health problems and psychiatric concerns and bad guts and lots of things which are not to do with CF, mainly because modulators have kind of fixed it. But I'm the CF GP in many ways, which is I always find very interesting and stimulating, keeps me on my toes. If I may, the flip side of this is that medicine, all specialties, becomes increasingly more complex, complicated, detailed, and there's just more of it. The medicine that Ellie and I learned at medical school some decades ago is a fraction of what we have to teach now. But we have to teach it, and there is an expectation that GPs do understand the complexities of what modulator therapies are, what monoclonal antibodies are, etc., etc. So there is a push that specialism is really important. How do we square off the two circles or circle off the two squares of having both?
Well, certainly generalists couldn't exist without specialists. So we can't, it's like you're building a building. You can't do the plastering yourself, and you can't do the foundations yourself or the structural engineering. We all need specialists, absolutely, yeah. James
So do you think as a specialist, do I need to be more generalist, or do I need to be left alone to be specialist, and we need to train more generalists? An unanswerable question, perhaps.
There are people's problems, as you say. If you've got a cystic fibrosis patient that comes in with complex issues, can you begin to have those conversations with them without sort of say, well, that's not my remit, I only deal with left shoulders or something?
I also think there's a responsibility on us, as Kay said, we need both generalists and specialists, and there is a Venn diagram where I think they do overlap, but it's also up to us to help our learners understand how the systems work, and not just be we're over there and you're over there, and therefore never the two shall meet, because they have to work across all the different systems. And if we just make it completely bewildering to them how everything interacts, then we're really doing them a disservice.
Yeah, I think your comments are about, is it my business or is it someone else's business? Is this the shoulder or is it something else? The lungs are attached to an entire person, but it's knowing it's not always. It sometimes doesn't sit well. There's some uneasiness about, am I leaving this or to someone else or not? Someone who comes into my clinic to have their asthma looked at who's ragingly hypertensive, do I spend an extra 20 minutes going through the hypertensive medicines, or is that someone else's business? Those sorts of questions I think crop up a lot, and students sit in with me and say, are you going to deal with this other thing in my specialist clinic? And there's sometimes there's a friction there of, I'd love to do that, but do I have the time? I'm hogging things and there are questions. So James McMillan first and then Tony Pelosi next. James.
Thanks very much. Can you hear me all right? Yeah.
Yeah, you're all good.
Great, thanks. So firstly, thank you very much for the book. It has been very much in my thoughts over the last year as I work my way into a PhD. And I just wanted to share my lens on it, really. I suppose, I assume most of you know me, but I work in the general practice department here, having been a GP for quite some time. And part of my remit is trying to figure out how we contribute to this medical curriculum, and just sort of share my lens and where I'm at in my thinking. I mean, I wonder, I suppose I believe there are merits in decoupling generalism from general practice in an undergraduate curriculum. Now, you can't do it completely, obviously, because general practitioners are the experts in generalism, I would say, because they do it the most, and they're sort of trained to do it, however you conceptualize it. But the conceptualization of generalism, I think, is the difficult thing. I found it quite hard to articulate over the years, as we try and sort of nudge our way into, the block structure, traditional medical curriculum, about, what is it that you do? What is it that you bring? What is different? How do you contribute to this program that's already in place and already established? And it's quite hard to capture it, really, to articulate it, really, but we can see the relevance that it has to our patients, and it sort of feeds into the commentary that Lindsay and Kay did and provide in the book. So, and then I mean, I at the end of my journey, I expect there to be a lot of, general practitioners will be in a good place to deliver this, but I fully expect that it's not, we don't have sole domain over this. So part of the work that I'm looking at is trying to figure out what this still quite difficult concept of generalism, when you look at all the stuff that's been presented today and what it means, what does that mean in undergraduate medical education? When we talk about generalism in undergraduate medical education across the board, what does it look like at the minute? And using the language that we've got at the minute around things like competencies and outcomes and knowledge and skills and attitudes, what is it that we are expecting at the end of 5 years, in our case, students to be able to do or know or believe, or however we frame it? And then it's how, I suppose, we can contribute, generalists and specialists alike, if you like, to that. What works best? What do we know works best? What are the barriers? What are the enablers? That kind of thing. So yeah, I don't think I really have a question there. I suppose in some ways I'm inviting the experts to come in and pick me apart or comment or whatever, but I guess that's the lens that I'm looking at it through at the minute.
Okay, there's a couple more hands, so I'll just maybe go through the questions because we're over time, but I think Lindsay and Kay are happy to stay just for a few more minutes. Tony, new face to Grand Rounds, welcome. You're muted, I'm afraid.
Unmute. Sorry, unmute. What a great talk, and like all great talks raise a million more questions than answers, and including James's point as well there. But it was that fruit bowl that got to me that you showed, because the fruits were far too big, because they had a neurology fruit, a rheumatology fruit, a surgery fruit, an abdominal surgery fruit. And then in the middle, God help us, you had a big psychiatry apple. And just to warn you all, be afraid, be very, very afraid about the psychiatric subspecialization and subspecialization and even subspecialization within of all disciplines, psychiatry, the other thing. So with what Tom was saying there, you said that there has to be generalists, and generalists can't have generalists without specialists. But should there not have to be a change where every specialist has to be generalist within their broad field, and they're allowed a special interest?
Yeah.
So, Tom, you would return to be not even a respiratory physician. You'd be a general physician with this incredible special interest in cystic fibrosis. And then you work out the time required with your management, and not with management, with policymakers, and probably with your local general practitioners as well. And for psychiatry, I see it as the only, the only solution to save the whole of psychiatry from absolute doom. Everybody has to be a general psychiatrist, and then they can choose their special interest and carve out a few sessions for that.
And someone who spends a not insignificant amount of their time with some of my patients going, well, they can't go to this psychiatry clinic because now they're back drinking. So now they need to go back to the alcohol service. So now they need to go here. So with my patients bouncing around from pillar to post and me just cutting and pasting bits of referrals to another bit, I completely agree. And the logistics of it, I appreciate, are very complex.
I am ashamed. I'm part of it, actually. I'm part of it.
I'm going to try and get to the last couple of questions. One is Liz Estabrook.
Hi there, guys. So yes, my name's Liz, and I'm a consultant in general internal medicine in Southampton, and I'm at the University of Dundee remotely in medical education. And so I really enjoyed your talk. There's actually a new curriculum for general internal medicine in the hospital, which you may or may not have heard of. I know Dr. David Marshall is at the University of Glasgow, and he's been very involved. And I guess I was interested in your thoughts as to where you see inpatient general internal medicine. I think there's been expansion of the program in the NHS England, less so in Scotland, but I know that that's an interest for development as a part of this solution. And the UK is unique in the sense that we don't have generalists running the majority of the medical service in hospital. America, Europe, and Australia, most of the major healthcare systems have generalists doing that, and whether you see the UK contributing back to that system or otherwise, and just your thoughts on the inpatient side as well.
I'll give my 2 pence worth. I think from a patient's point of view, we have to have this expertise. Our patients don't come and end up on a medical ward with just one thing wrong with them. If you just look at the population rates of multimorbidity, for example, it's the norm now. It's not the exception. And so I remember when I was a junior doctor in the ward, and quite often, if, for example, you were on a particular ward, anything that wasn't that specialty's domain became the responsibility of the junior doctor to navigate. And that was somebody who was maybe 1.5, 2 years qualified, who was then almost by default expected to be the expert in everything, or then just to phone the med-reg if they didn't know what to do. And so I think we're doing our patients a disservice if we don't think about how we actually align the systems with what our patients need.
That still happens, I'm afraid, Lindsay.
And
thank you.
The last question goes to the enigmatically named Google Pixel 8. Hello, Google. Or do you prefer Pixel? You're muted. There we go.
Sorry, yes. Hiya. Can you hear me?
Yeah, we can now, yeah.
Sorry about that. I don't know why I'm Google Pixel 8. It's probably on my phone. Anyway, I'm Jacqueline Benenbrook. I'm a rural emergency physician on the Isle of Skye. And obviously, rural areas are very, very much reliant on generalism. So our team is made out of GPs and ED consultants. We don't do any normal GP stuff. We just run the hospital with our team, where we run the ward, the ED, the out of hours, and everything. So yeah, I think we definitely need generalists, but not just in rural areas, but certainly we need them for rural areas. But as even as somebody else sort of earlier said, I think general sort of specialist medics also should be and remain medics as in a generalist way. Which at the moment I'm actually in Caithness General Hospital, and the medics from Raigmore Hospital from Inverness come to Caithness on a sort of rotational basis to run the general ward, where obviously this week we had a rheumatologist who was very much keen to keep his generalist skills up to date as well. So he comes here to do that. So yeah, within the hospital we need generalists, and outside the hospital we need generalists, but we definitely also need specialists to help us be a good generalist.
Absolutely. I was just wondering whether we've got the whole sort of foundation program upside down, perhaps. And I know in some countries they have, a couple of years, everyone does in primary care, where they do all of their medicine and get to see people in the community before they can then opt, as you were saying, into specialist training if that's their choice. Yeah, but it's I know they do that in some countries, and they have much better outcomes and much cheaper. And I know not Colombia, where is it? One of the South American countries does that, and they have much higher life expectancy than North America for half the price. And it's an achievable, doable thing if you look internationally. Yeah.
Thanks very much for everyone's input. I'm going to draw things to a close, as we all have things to get away to do. Thank you very much to both of you in the virtual room, and also to our video speaker for an excellent talk. And as was mentioned, has stimulated lots of thought, discussion, and questions. For those of us old in the tooth, I think back to what my training was like, what it was like before me, what it's like now, what it might become in the future, and it has changed almost 180 in many ways, and I think it's important we have these discussions. Things don't happen overnight. Med school students take 5-6 years. Training takes another 10. Yeah. But it's important we don't just blindly head down tracks of this is what we've done, so this is what we're doing, and this is what it will always be. So thank you very much for the stimulating conversations today. Thanks to everyone for listening and hanging on. I will send an email to tell you when the next talk is. I think we don't have another talk until the end of September, but if someone jumps in and volunteers, then please do that and I'll give you a slot. Other than that, I think we're pretty much full through October, November, and have slots in December. So if you do want to talk at Grand Rounds, please let me know and I'll slot you in. Thank you very much. Enjoy the rest of your day and have a good weekend. Take care, everyone.
Thank you all. Bye.
Cheerio.